Uh, I would like to welcome you all for this first webinar organized by the Sri Lanka Society of Gastroenterology for the year 2022. Today, our topic is liver transplant, peri and post-operative care of a liver transplant patient. To take us through the topic, we have one of our rising stars in our society, Dr. Udita Dasanayaka. Udita is a product of University of Peradeniya Faculty of Medicine. He completed his primary MBBS in 2008 with many distinctions and second class honors. And he also, after completing his primary degree, he obtained MD in gastroenterology in 2014. And after completing his local training, he was trained for 2 years from 2016 to 2018 in Adam Brooks Hospital, Cambridge, in hepatology and liver transplantation. Upon his return to Sri Lanka, he has managed many cases, many patients with many pre and post liver transplant patients. And currently he is serving as a consultant gastroenterologist and hepatologist in Teaching Hospital, Batticaloa. And he's also serving National Hospital of Sri Lanka as acting consultant gastroenterologist and hepatologist in organ transplantation unit at National Hospital. Without further delay, I invite Dr. Udita to take the proceedings from here onwards. Udita, over to you.
Thank you so much, sir. Thank you very much for that very kind introduction. First of all, before starting, I would like to thank Professor Rohan Sirivardhana and the Council of the Sri Lanka Society of Gastroenterology for giving me this opportunity to talk about this topic, which is very close to my heart. Let me just start sharing the slides. So when I was first asked by Dr. Kulisha to talk on this topic, I have to admit I was a little overwhelmed because this topic, liver transplant, peri and post-transplant management, is actually more of a topic for a conference rather than just a single lecture. But then I sort of talked it over with Dr. Kulisha, and I understood that this was generally, we needed to give an overview as an introduction into the peri and post-transplant management of liver transplant patients. So what I'm going to try and do is just stick to the hepatological perspective, because there are a lot of surgical, anesthetic, critical care issues that need to be dealt with as well. And I would rather not go into detail on that because I'm not an expert on that. So just to give you a brief outline of what I'm going to talk about, basically, we'll just talk about the history of liver transplant, because we owe it to the pioneers to talk about it. And of course, I'm just going to touch on peri-transplant investigations and management, what we do when a patient comes for a transplant and what we do immediately after. And of course, the bulk of this lecture, I'm just going to talk about the early post-transplant management and most focusing on immunosuppression, because that is something that the hepatologist is in charge of, and that is what we manage. And of course, I'm going to talk about prophylaxis, especially prophylaxis against infection, because that is another important topic. And after that, just to sort of have a practical input as to what the management process is like, we'll just go through a case history of a recently transplanted patient and just touch on the local perspective as well. So the understanding of the liver, the humans, we understood what the liver was and the amazing regenerative capacity of the liver for a long time. A good example is the story of Prometheus and the Caucasian eagle from the Greek mythology. Because what the story there is that Prometheus was an immortal who stole fire from the gods from Mount Olympus and handed it over to humans. And as a punishment for his act, he was chained to this rock, the rock of Caucasus, and this eagle called the Caucasian eagle would come and eat his liver, and every day. So the theory there was, when the liver was eaten, the liver would regenerate the next day, and he would not die because he's anyway immortal. So this is a good example of the understanding of the amazing regenerative capacity of the liver by ancient humans. So although this liver was studied extensively, and the liver was we had a basic understanding for a long time, surgeons and doctors were very hesitant to touch the liver, because it was understood that it was a very vascular organ, that it bled very profusely, and that it was extremely difficult to control that. And although at the beginning of liver transplantation, solid organ transplantation, both kidney and liver was basically started simultaneously, the experiments. But the kidney was, it progressed much quicker because that was a heterotrophic transplant. You didn't need to remove the native kidney in order to transplant a new kidney. But with the human liver, it was very challenging, because first you had to remove the liver in order to transplant a new liver. And that needed a lot of surgical techniques, and there was a lot of requirements and from the anesthetic point of view, and basically the operative management was extremely challenging. So the first successful human liver transplant was done by Dr. Thomas Starzl in the US in 1967. And this was, as you know, the humans landed on the moon in 1969. And actually, at the time, the first human liver transplant was considered to be equal to the humans landing on the moon, achievement-wise, because it was something that could not be imagined a few years before. So since then, there have been a remarkable progress in the outcome and survival for transplanted patients. So this was mainly due to the improvement of surgical and anesthetics techniques initially in the first 10-20 years. But then the period of post-transplant management new developments were actually responsible for pushing that survival even further. So this is Dr. Thomas Starzl, who is called the father of modern organ transplant. He is the one who pioneered the surgical techniques and actually performed the first transplant surgery. While almost simultaneously on the other side of the Atlantic, Professor Roy Kahn, who's from Edinburgh Hospital, was the one who in 1968, 1 year later, he did the first liver transplant in the UK. And actually, he was the one who pioneered the use of azathioprine and later cyclosporine, or new immunosuppressive techniques to make sure that the graft survived for longer. So both of these pioneers were equally responsible for the progress of the early transplant period. So this is just a timeline from the 1960s for now, and basically it shows the discovery of different immunosuppressants, because I mean, although it's not completely 100% due to the immunosuppressants were a major factor in improving survival in liver transplanted patients. So when they started doing liver transplants, the 1 year survival was only 9%. So it was very dismal, and it was very, the outcomes were very poor, and people were questioning whether this was a feasible long-term option. Then by the 1980s, early 1980s, at the time of the introduction of cyclosporine, this was increased to around 70%, that with steroids, azathioprine, and cyclosporine. And at present, this is in developed countries in good transplant programs, this survival is around more than 90%. So this is from the UNOS database. So as I said, the 1 year survival is around 95% in both deceased donor and living donor transplants. So it's a remarkable achievement compared to what we were only 50 years ago. Now, a common question I get is whether there are any major guidelines, in society guidelines or national guidelines on management of post-transplant patients. But if you go through the guidelines, you can see that they are mainly restricted to institutional protocols. It's not, you don't have this all-encompassing global guidelines. So this is actually due to a lot of reasons. The first thing I think is because post-transplant care is highly individualized. So what this now recommend is a la carte sort of immunosuppression and other medical management. So because of that, it's very difficult to give a very fixed protocol to manage all patients. And of course, there are regional differences in patterns of complication and issues. If you go through what the common, because if you go through the literature, we'll be discussing this. The acute rejection or immediate post-transplant rejection is quite common in Europe, and because of that, they are very aggressive with their immunosuppression strategies. But if you talk to doctors in India who are working in high-volume transplant centers, they are a little sort of relaxed on some aspects of immunosuppression, because maybe that rejection rates are a little lower, although it's not publicly it's not confirmed by randomized trials. And of course, there are policy decisions, maybe mainly due to cost reasons, and of course available resources, because very soon I think this liver reperfusion strategies and things will come into the protocols in the US and the UK, but it will take some time for that to come to less developed countries. And of course, to some specific questions in managing post-transplant patients, there may be a lack of clear evidence, because lack of randomized control trials sort of addressing any specific problems. So before you start to manage a post-transplant patient, there are a lot of things you need to know. These are just some of these things, but these are the most important things that I could think of. So first of all, you need to know the recipient details. You have to know what the cause of the liver disease is, and what the complications the patient had due to the liver disease, and of course the comorbidities and the renal function. Because cause of the liver disease, if the patient has autoimmune liver disease, that's just an example, it will have implications on the long-term immunosuppression management. And of course, the renal functions are very important, because again, as we'll discuss in the coming slides, it's very important in deciding on the initial post-transplant management. And of course, the graft details, the quality of the graft and the size mismatch, especially in living donor liver transplants, and of course the cold ischemic time. And of course, you need to know whether it's a deceased donor transplant or a living donor transplant. And deceased donor transplants in the West, you have to know whether it's a DBD or donor brain death transplant, or a donor cardiac death transplant, or DCD transplant. And of course, everyone, although surgical details are especially important, it's important at the time of the surgery. It's also very important to know the surgical details in the long-term management, because that will have an impact on the complications. So you have to know about the arterial anastomosis, you have to know about the venous anastomosis, what the IVC anastomosis the type is, and of course the biliary anastomosis, whether it's duct to duct or a loop. And of course, you have to know about the blood loss and the intraoperative complications, because that will have an impact on the immediate post-transplant management. Of course, the peri-transplant management is basically according to the institutional protocols. So there are routine investigations that we do when a patient comes in, is called in for a transplant, and that is something that is very, it has to be decided by the institution. But in specific cases, there will be additional investigations like a CT scan. If you need to go into the venous circulation, the portal venous thrombosis or something like that, but that will be decided on a prior multidisciplinary team discussion. So according to that, some patients may need any specific investigation. And of course, another very important thing is you have to manage the patient's expectations, because most patients in a deceased donor transplant program are not transplanted at their first calling. So they may be disappointed when they don't get a liver when they are called in the first time. So you need to manage that. And of course, the immediate post-transplant care, the important things are the fluid management, the line and drain care, and the analgesia. Of course, although I can give a summary of this, I would rather not touch on this, because this is the realm of the anesthetists and the critical care specialists. So they will manage that, and we will just skip over that, because we have a lot of content to cover. There's one thing I want to highlight, important investigations in the post-transplant period, is about the Doppler study of the liver graft. So you know that there are a lot of vessel anastomosis in a liver transplant graft. So the most important problem from a vascular point of view that can come up in the immediate post-transplant period is a hepatic artery thrombosis or a stenosis. So this is something that we need to exclude in every patient, and we need to keep an eye on this because this is important for managing the complications. So the first post-transplant Doppler examination is performed within the first 24 hours of surgery. And this is basically to get a baseline. And of course, it's repeated as clinically indicated. Because if you detect early, if there is a thrombosis or any issue in the arterial flow or a venous issue, if you detect it early and treat it early, it will reduce the incidence of graft failure, because it's a very common. If it's not detected, it could be a very common reason for liver graft failure. And especially in the long run, if a patient after liver transplant comes with altered liver functions, a Doppler study of the liver graft is something that we do as a first line, because we need to exclude vascular complications before moving on to other possibilities for the high liver function. So this is just a image of the normal vessel flow in the hepatic artery in the post-transplant period. So you measure the resistive index, and that will give you an idea about the flow. So moving on to the main topic of discussion. So there are several concepts that are now very widely discussed in the immunity in liver transplant patients. So there's immune rejection, there's immunosuppression, and recently now it's the concept of immunotolerance is actually coming to the forefront, because it has been known for a long time that the liver is a very tolerogenic organ. So compared to other solid organs, the liver graft, if you take a liver from someone and attach it to another person, it has more chances of survival because it has inherent tolerogenic qualities. So this is due to a lot of reasons. So one thing is its microanatomy, the vascular structure with the sinusoids, so that also helps. The cellular composition, because it has a lot of the dendritic cells, antigen presenting cells, that sort of balance out the rejection with some signals to promote immune tolerance, and the cytokine microenvironment, which contributes to easier acceptance of liver versus other solid organ transplants. Actually, initially when people were experimenting with liver grafts, when they were experimenting in animals, especially in the pigs, the liver was hardly ever rejected. So people were initially thinking that the liver did not require any immunosuppression post-transplant, but unfortunately in human trials it proved that it was not the case. So ABO matching alone is sufficient. So if you don't need to check the cross matching, you don't need to check the rhesus typing, it's just the ABO compatibility is sufficient. And of course, ABO incompatible transplantation is also possible and is now being widely practiced, especially in living donor transplants, because in living donor transplants, you can plan the transplant, and then you can do plasma exchange and remove the antibodies from the recipient, and make then that would make the ABO incompatible liver graft tolerate better. But it's a little difficult to do with diseased donor liver transplants, but it's not impossible. So the current rates of acute and chronic rejection, if you go through the global literature, is around 10 to 40% for the acute rejection and about 5% for chronic rejection. But in our personal experience, I think this would be around more towards the lower end, towards 10%, rather than towards the higher end in our local population. Although, of course, we don't have enough numbers to sort of very concretely prove that. So the important concept now is that immunosuppression weaning, or completely weaning of all immunosuppression, can be achieved in around 20% of the selected transplant patients. So basically, there are several trials which have tried mainly after 5 years of liver transplant in very stable patients who have not rejected their livers at any point. they have tried to withdraw the transplant, the immunosuppression, and that has been actually successful in about 20% of cases. And what it looks like, the longer you wait, it's better. So if you do it after 10 years, if the patient has been stable for 10 years, there is more chance that the immunosuppression weaning can be achieved. So this is just a diagrammatic representation of the rejection process, how it happens. So basically what we need to know is that when you take the liver graft, and when there is a cold ischemic time, and there's ischemic injury to the liver graft, and that exposes the liver graft host, the liver graft antigens to the recipient immune system once the liver is transplanted. So that triggers the whole the immunogenic reaction that leads to rejection. But of course, simultaneously in liver grafts, there is another reaction which leads to, there are two pathways, and one pathway supports liver tolerance. So if there is overstimulation of the rejection pathway, of course, especially in the immediate post-transplant period, the patient can still reject, but with time that is reduced. So if you look at the cellular basis or the cellular mechanisms for liver transplant rejection, there are basically three signals that are discussed. So signal 1, signal 2, and signal 3. So there is the MHC, the major histocompatibility complex molecule, which does the antigen presenting, and that antigen presentation, and that is, there is a co-stimulatory signal at the same time with the CD80 and 86 and the CD28 molecules on the cell surface. And once the T lymphocyte is stimulated, it produces interleukin-2, which promotes proliferation of target lymphocytes, B and T lymphocytes that give rise to the immunogenic reaction. So if you look at the immunosuppressive drugs, steroids, of course, work at different levels. It inhibits the antigen presenting cells, and it also inhibits the transcription of the interleukin-2 gene. So as we know, it works in different levels to reduce a patient's immunity. But the important drug that we use are the calcineurin inhibitors, tacrolimus and cyclosporin, inhibits the calcineurin pathway, which is stimulated by the first signal 1. And azathioprine and MMF, which are antimetabolites, inhibit the cell cycle, which reduces the lymphocyte proliferation, again giving rise to their immunosuppression activities. The other important drug that we commonly use is interleukin-2 receptor antagonist, which is drugs like basiliximab. So basiliximab actually works on the interleukin receptor and blocks the third signal, or the signal 3. So all of these, what you can see is that all of these agents work at different points. So when they work together, there is a synergistic effect for immunosuppression. So that is why we combine the drugs, and that helps also to minimize the side effects from a single drug. So the most important immunosuppression class are the calcineurin inhibitors. So the first calcineurin inhibitor discovered was cyclosporin, which was discovered in 1970s, but it came into regular use in early 1980s in liver transplant patients, and that caused a major change in outcomes and major improvement in the liver transplantation management. Of course, tacrolimus, although it has the same effect, is a macrolide antibiotic. And although it is similar in mechanism, the potency of tacrolimus is estimated to be about 100-fold greater than cyclosporin. So that is important. So the next question was that whether this potency translated to better post-transplant or better clinical outcomes. So I'm just giving one example. This is a Cochrane study done, Cochrane review done in 2003, which compared cyclosporin and tacrolimus. And what they summarized was that tacrolimus is superior to cyclosporin in improving patient survival, graft survival, and preventing acute rejection. But it increases post-transplant diabetes. So treating 100 recipients with tacrolimus instead of cyclosporin would avoid acute rejection in 9 to 7 patients. So, sorry, nine patients, and steroid resistant rejection in 7 patients respectively. So that is a significant amount. So because of that, now tacrolimus is by far, almost 100% the preferred drug in managing immediate post-transplant liver transplant patients. But unfortunately, tacrolimus is a very temperamental drug because it is very specific. You need to be very careful in order to maintain proper tacrolimus levels in the blood. The main issue is it is inhibited at absorption level by food or drugs. So you have to be very careful. And when a patient takes tacrolimus, it has to be 1 hour. You have to leave 1 hour on either side, usually before meals, and 1 hour before the tacrolimus you don't take anything, and the meals should be delayed 1 hour after the tacrolimus dose. So you have to leave 1 hour on either side to make sure that the drug is absorbed properly. And of course, there are numerous drug interactions. This can be at the cytochrome P450, P3 cytochrome level, and of course, or it can be at the P glycoprotein level. So it's very important when you start a transplant patient on a new drug to check whether there are any drug interactions with tacrolimus, because that is the one that interacts with most drugs. And of course, the metabolism of tacrolimus varies between individuals. So this mainly because of the cytochrome enzyme activity. So some people will need very high doses of tacrolimus, whereas other people will need relatively low doses of tacrolimus. So because of all this, you have to monitor the trough levels very frequently. And adverse drug reaction wise, the main thing we worry about is renal impairment with tacrolimus. So there is a reversible component caused by spasm of the afferent arteriole when you give a patient tacrolimus initially, and this can lead to a reversible component with interstitial fibrosis and nephrosclerosis, which can happen later. And of course, tacrolimus can, in the short term, give rise to neurotoxicity, and this is the most common reason that we switch to cyclosporine from tacrolimus. So in those cases, patients with tacrolimus-induced neurotoxicity, we can switch to cyclosporine to avoid those side effects. And of course, hyperkalemia, hyperglycemia, hypertension, and hyperlipidemia are all long-term side effects. But gingival hyperplasia and hirsutism is only with cyclosporine, not with tacrolimus. The other important category of drugs is antimetabolites. The main things are azathioprine and mycophenolate that we use. And actually, starting a patient on antimetabolite, of course, we use them commonly for steroid sparing effect. And of course, it reduces the dose of CNIs or calcineurin inhibitors as well. And then it reduces the dose and hence the toxicity of CNIs. But it has a relatively delayed onset of action. So if you want to treat an acute rejection, or if you want to get an immunosuppressive effect immediately, antimetabolites are not the drug to use. So it will take some time, and azathioprine takes longer than MMF. So MMF is generally preferred due to more potent action, the lack of nephrotoxicity, and the lesser risk of acute cellular rejection compared to azathioprine. But there is no difference in 1 year survival, which has been proven. So in some centers in the UK, until very recently, they were using azathioprine instead of MMF. Of course, with MMF, the major side effects are bone marrow suppression and GI side effects. And azathioprine, important place where azathioprine is still used is women of childbearing age if they are planning a pregnancy, and males planning fatherhood. So it's recommended that patients on MMF, males, if they want to become a father, if they want to plan having a child with the partner, then they have to stay off MMF for around 90 days. Of course, now this evidence is changing on this, and this recommendation may change in the future. So just an interesting case that I came across in Batiklo. This is a case of MMF-induced IBD-like colitis in a patient, post-transplant patient who presented with melena, basically. And the patient sort of improved quite dramatically when we stopped the MMF and managed the diarrhea. So the other group of drugs that we use in post-transplant management is the mTOR, or the mammalian target of rapamycin inhibitors. So the main drugs here are sirolimus and everolimus. mTOR inhibitors have anti-proliferative and anti-angiogenic properties, which may translate into anti-tumor effects. So out of the two, everolimus is usually preferred due to higher bioavailability and more potent action. And of course, the main reason why we use everolimus is to preserve the renal function by reducing or stopping the calcineurin inhibitors. And in some patients, because of this anti-proliferative effect, they prefer everolimus in patients for patient transplanted for hepatocellular carcinoma, because that might improve their outcome. There is some evidence to suggest that, but it's not universally implemented. The important adverse drug reactions of everolimus, the first thing is poor wound healing. So because of this, we are very hesitant to start a patient on everolimus immediately post-transplant, because the transplant surgery, there is a very large surgical scar, and this is very well known to impact wound healing. And if a patient on everolimus comes for a herniatomy or a routine surgery, they are usually switched to tacrolimus during the perioperative period until the wound heals. And of course, although it is used to preserve renal function, in patients with pre-existing renal disease, it can actually worsen the renal function. So it's not recommended to continue everolimus if you have proteinuria more than 0.8 grams per day. And of course, other side effects include things like hyperlipidemia, myelosuppression, and pneumonitis. The other important group of drugs that we use commonly is the interleukin-2 receptor monoclonal antibodies. The main one we use is basiliximab, although daclizumab is also falling into the same category. So usually they are used as induction agents to delay the introduction of calcineurin inhibitors. So when we give basiliximab, we usually give 20 milligrams on day 0 and repeat that on day 4. This is just to have an immunosuppressive effect until and delay the introduction of calcineurin inhibitors. But now it's thought that there is a subset of regulatory subset of T cells called the Treg cells, or the regulatory T cells, which actually promote graft tolerance. And now there is a discussion on this interleukin-2 receptor antibodies, because they may deplete the regulatory T cells, and in the long run, that we may have a sort of a deleterious effect on the long-term graft survival. And of course, we also use cell-depleting agents, but not very commonly. Things like alemtuzumab or Campath, which is an anti-CD52, and the antithymocyte globulin. Usually, alemtuzumab is used as an induction agent, while ATG is used to treat steroid-resistant acute rejection. So now that we have all these drugs, how do we combine them to make a protocol? So this is the most common immunosuppression protocol that is used, I think, all over the world. So usually during the perioperative, during the operation, during the amniotic period, we give methylprednisolone 500 milligrams as an induction agent. So this is not purely for immunosuppressive effect. It is because when you release the IVC clamp, you get all the toxins that is building up due to ischemia in the graft liver, and that is released into the host circulation. So this is just to this is thought mainly to sort of combat that inflammatory or the effect of those toxins into the circulation. So that is why we use the methylprednisolone bolus. And after that, usually for the first 3 months, we combine steroids, tacrolimus, and MMF in the patient management. And with the tacrolimus, you aim for higher trough levels in the immediate post-transplant period, around 5 to 10, and then you can gradually lower the trough levels according to the period after transplant. So the steroids are usually weaned off and stopped at 3 months. But of course, this is not a protocol, one protocol that will fit all. because, for example, in a patient with autoimmune hepatitis, because there is a higher risk of what we now call eosinophil-rich rejection or recurrence of autoimmune hepatitis, you can sometimes we continue the steroids for a longer period, for more than 3 months, sometimes up to 1 or 2 years. And of course, as I said, in some patients like hepatocellular carcinoma patients or patients with significant renal impairment, we may combine the tacrolimus with everolimus, and the trough levels, the target trough levels will actually be lower than this usual protocol. And of course, the final thing I want to talk about in immunosuppression is renal sparing in immunosuppression. So in patients who have had pre-existing renal disease and patients who have had a significant renal hit during the surgery may need a delay in the introduction of the calcineurin inhibitors, because they are also known to have short-term and long-term nephrotoxic effects. So the commonest thing that is used is basiliximab. As I mentioned earlier, you give basiliximab on day 0 and day 4 and start calcineurin inhibitors from day 5. Of course, some clinicians and some institutions do not do this. But of course, if you want to talk about renal sparing immunosuppression in maintenance immunosuppression after the immediate post-transplant period, combining calcineurin inhibitors with MMF, this will help to reduce your calcineurin inhibitor levels, as in the target levels, which will help the kidney. And of course, you can combine or substitute with everolimus. So those are the two strategies we use in maintenance immunosuppression for renal sparing. That is about immunosuppression. And with regards to post-transplant prophylaxis, there is post-transplant infectious prophylaxis, thrombosis prophylaxis, and stress ulcer prophylaxis. Of this, the most important thing to discuss is prophylaxis of post-transplant infections. And I would just like to direct you to this article which was published in New England Journal of Medicine 2007 on infections after solid organ transplant. I think that's a very good article, which sort of outlines the concepts behind the post-transplant infections and the patterns of post-transplant infection. So what it says is, in the first 6 months, because we are giving more intensive immunosuppression, that is the time when you get these opportunistic infections. And in liver transplant patients, this translates to the first 3 months, because that's when we give the steroids and the combined high dose immunosuppression. Of course, transplant infections earlier than that are mainly due to recipient-derived infection. And after 6 months, when the patient is on minimum immunosuppression, then that is the infections are sort of similar to the community-acquired infection patterns. So in a liver transplant patient, this critical period for opportunistic infection is usually in the first 3 months. And that is when we give the post-transplant antibiotic and antifungal prophylaxis. So antibacterial prophylaxis, of course, is actually according to institutional guidelines. And that actually, if you follow the European guidelines in Sri Lanka, that will not be enough, because especially our critical care units, ICUs, have a lot of multi-drug resistant organisms. So sometimes we need to step up on the antibacterial prophylaxis. So you have to consider whether the patient is colonized by MRSA, whether there's a history of ESBL, and of course you have to look at the donor colonization, and of course allergies also have to be taken into consideration. And usually antibacterial prophylaxis, ideally we should stop within 48 hours if there is no evidence of infection in the patient. Fungal prophylaxis, of course, routinely we start fluconazole 100 to 200 milligram a day. Fluconazole has a very good oral bioavailability, so it is you can switch to you can give oral as soon as the patient can tolerate oral fluids or oral feeding. But the important thing we need to know is fluconazole is an enzyme inhibitor, and it will increase your TAC levels. And importantly, after 3 months, when you stop the fluconazole, your TAC levels will fall. So you have to monitor your TAC levels during that period to make sure that they don't reduce too much. But of course, there are high risk patients. For example, patients transplanted for acute liver failure, patients who have had a second liver graft, patients who have renal impairment on renal replacement therapy, and patients who have had massive transfusion, and also repeat abdominal surgery due to bleeding or some reason within the first 7 days of liver transplant. These patients may need stronger prophylaxis. So then you have to discuss with the microbiologist, and you might need to change the antifungal prophylaxis. And cytomegalovirus prophylaxis, of course, we know that it depends on the match between the donor and the recipient. So the CMV, what we call CMV mismatch, is when the donor has IgG positive and the recipient is negative for CMV IgG. So then the recipient is at risk of de novo infection due to the donor liver and the CMV particles being introduced. So these patients need valganciclovir prophylaxis from immediate post-transplant for 3 months, again during the period of the steroid use. So the recommended dose is 900 milligrams once a day if the creatinine clearance is normal, and according to your renal function, you can go down on the prophylactic dose. But there's now some evidence that low dose or 450 milligrams once daily valganciclovir is also safe and effective as a prophylaxis measure even in patients with normal creatinine clearance. Now, when the donor and recipient are both positive, or if the donor is negative and the recipient is positive, there is still a risk of CMV reactivation. But in that case, what the recommendations usually are is to repeat the CMV PCR weekly in these patients. But it may be more cost effective, and what we practically do is we just put these patients on prophylaxis, because getting an urgent CMV PCR is sometimes difficult. And of course, if both are negative, if the donor and recipient are both negative, yes, you don't need to do any routine screening for CMV PCR with CMV PCR. You don't need to put on prophylaxis, but you have to consider screening if there are features of cytomegalovirus disease like unexplained pyrexia, leukopenia, or diarrhea. And of course, pneumocystis prophylaxis is indicated in all liver transplant patients during the first 3 months. If the patient receives these cell-depleting agents, ATG or Contact, and patients with lymphopenia receiving high-dose immunosuppression at any time post-transplant. So the first line is cotrimoxazole, 480 milligrams per oral 3 times a week, Monday, Wednesday, Friday. Of course, if the patient has any sulfur allergy, we have to change that. And you know that cotrimoxazole is also prophylaxis for toxoplasma as well. Right. So that is about post-transplant infection prophylaxis. When it comes to post-transplant thromboprophylaxis, it's that decision when to start thromboprophylaxis is a surgical decision depending on the risk of bleeding and the risk of thrombosis, mainly which is sort of this is sort of the impression the surgeon will get during the time of the liver transplant. But basically, you need to start low molecular weight heparin prophylaxis as soon as possible, and aspirin ideally for all patients, and all patients on discharge should be on aspirin. And of course, stress ulcer prophylaxis, like any major surgery patient, you can put on ranitidine or PPI. PPI, if the patient has already been on PPI, better to continue the PPI. And you have to continue stress ulcer prophylaxis for the duration of steroid treatment. So keeping all that in mind, we will just go through the post-transplant management in one patient that was recently transplanted in the liver transplant unit at NHSL, Colombo. And thank you for Ramdullah for in very short notice for preparing this information on this patient. So this was a 36-year-old male with decompensated CLCD, which was thought to be alcohol or ethanol induced. So the male was 17 at the time of the surgery, but most importantly, this patient had recurrent episodes of leukopenia and opportunistic infection, mainly due to the hypersplenism, and patient had recurrent admissions due to that. And there had been some hematemesis episodes as well. And the patient had been treated for pulmonary TB in 2018 and treatment complete. And the eradication was confirmed. So CT, echocardiogram, nothing to worry. So basically, the patient had sort of high normal renal function, and there's leukopenia, and there is thrombocytopenia at the time of pre-op transplant. So this is about the duration of the surgery. As I said, we need to know about all these details before going on to long-term management. So this is the pre-op investigation. So this one, the first line is basically the immediate pre-op investigation. So in that, you can see the creatinine is actually at the higher limit of normal. And then post-transplant as well, it is around the higher side. So the first question we had when the patient came to the, I mean, there were a lot of other issues, but one of the main questions we had was whether to start this patient on renal sparing immunosuppression. But when we look back, the patient does not have any history of diabetes. There is no history of proteinuria. And at the time when the patient was brought into the ICU, the patient was producing adequate amounts of urine, about 50-60 cc per hour, and everything looked stable. So instead of going for renal sparing immunosuppression or basiliximab, we decided to start on low-dose tacrolimus with an aim to increase it very quickly. And then if you can see on about the third day post-transplant, the patient was sort of progressing and patient was stable, and there was a sudden increase in the liver function, the liver enzymes basically. So as you know, this very high liver functions could be due to toxic, ischemic, or viral. And what we thought initially was whether this was some sort of a vascular issue with the liver graft. So immediately we ordered within the first 24 hours, we did a liver Doppler graft. But at this point also, we repeated the Doppler graft, but that showed a very patent artery with good flow. So that gave us sort of, we were reassured, but there was no documented hypotension of the patient as well, but it could have been due to just one episode of sort of undetected hypotension or something which led to liver ischemia. So, but subsequently the liver functions gradually improved. And the next question we had was, as I said, this patient was regularly admitted for neutropenic sepsis. And again, the neutrophil counts, the total white cell counts and the platelet counts started trending downwards. And at this point, we discussed with the hematologist, and we gave one dose of granulocyte colony stimulating factor. After that, things generally improved. Of course, there are other reasons why the immunosuppression, the counts could drop, like because there is the hypersplenism is still there for the first 2 weeks of after the liver transplant, and the liver spleen will slowly regress after that. And of course, but I should note that we did not start MMF at this point. This is about 3 days after the transplant. So the patient was just on steroids and tacrolimus. And you can see that gradually the liver functions, the AST was gradually trending downwards and everything was settling down. So we were happy. So actually MMF has started on this day when the platelet counts rose to 40%. If you look at the guidelines, they say to wait until 50%, 50,000. But we started at 40,000 because it was clearly trending upwards and it was 1 week post-transplant. But you can see the liver functions are trending down, it's settling down. AST is, of course, settling down faster than ALT. So there were a lot of other, post-op complications like electrolyte imbalances, like hypocalcemia, hypophosphatemia, which were corrected. And of course, as I said, the serum creatinine and blood urea were a little on the high side, and we sort of managed them with fluid management. But we did not go for a renal sparing immunosuppression, and there were elevated liver enzymes and serum bilirubin. And of course, we started on a NAC infusion at the time of the rise when the liver enzymes shot up to 1,000. And of course, there was anemia and leukopenia, and of course, sinus tachycardia, and the patient was started on ivermectin. and oral thrush. So those are the main complications. And now the patient seems to be out of the woods. I think by tomorrow the patient will be discharged. So just to give a just general idea about the transplant programs in Sri Lanka, basically the 3-month survival, the first few months are the crucial months, mainly because of ICU acquired infections, because our ICUs are, we have a lot of sort of multi-drug resistant organisms, and especially if the patient is intubated for a long time, the patient will, if the patient develops ventilator associated pneumonia, then your outcomes will be very poor, right? So, but if the patient goes beyond that 3-month survival period, then there is a very good survival beyond 3 months. So around 30 to 40 patients are on follow-up at NHSL Colombo, and over the past 4 years, beyond the 3 months, there is 100% survival, and those patients are doing well. And more than 50% of these patients are economically productive. They are sort of going back to their jobs, because, as I said, you can wean off the immunosuppressions quite quickly. The patients don't need to be on steroids for a long time, and that means that the patients can sort of recover their normal function and go back to their normal lives much sooner. So that is very important. And of course, two male patients have actually become fathers after the liver transplant. As I said earlier, when the patient was on MMF, we switched to azathioprine when they said that they wanted to consider having a baby. And then after the child was conceived, after about the first trimester, then we switched back to MMF. So what I wanted to highlight was that if the patient sort of after the immediate post-transplant period, there is a very good survival, and these patients can go back to their normal life, and that would sort of, when planning a large transplant program, that would justify the cost, the per patient cost that we take on these patients, because these are not very cheap procedures, because we spend a lot of money, but that is we get a result out of that, because the patients can go back to their normal lives. And finally, what I wanted to highlight was that liver transplantation is a team sport, that you need a good team. You need a lot of specialized individuals, from transplant surgeons to anesthetists, critical care surgeons, hepatologists, critical care physicians, hepatologists, and of course the medical officers and other grades of staff who combine together, because usually, commonly liver transplantation and in any transplant program, a lot of people need to go beyond their normal duties, and they need to go work beyond their normal hours. They need to exert themselves more, and they need to dedicate themselves in order to make a transplant program a success. So, and there are a lot of physicians who work in the peripheries who actually are involved in the transplant program, and that is like sort of a just out of their interest. So I would like to dedicate this lecture to them. So thank you so much. I think that I tried to give a basic idea about what liver transplantation, the post-op management, the main principles are. And I would like to thank Professor Rohan Sirivardhana and the Council of the SLSG, and of course Dr. Kulisha, for arranging these very well-organized and informative lecture series, and giving me this opportunity to talk on this topic.
Thank you, Udita. Thank you for doing that very nice presentation on this very vast topic. There are a few questions, if you are okay with that. What is your view on single daily dose of tacrolimus for long-term immunosuppression?
Well, it is something actually that now is being widely practiced. I think the only so there is, I think there are a lot of industry-sponsored conferences and a lot of data on how that is more effective and that may cause less renal toxicity. The stumbling block or the confounding factor here is the cost. But actually, we have started about 5 or 6 patients on once daily tacrolimus, and so far our experiences have been good. And of course, the patient compliance, which is a major factor, is very, very high when it comes to once daily dosing. I think some centers in the UK have actually started using this very early. I think in King's or Royal Free, they are using once daily tacrolimus. And of course, Indian centers, they do use tacrolimus. And I think there is some evidence to say that because it does not, because when you take twice daily dose, the peak levels will be higher than a once daily dose. So that might translate to less nephrotoxicity. So I think there is a future for this if we can manage the cost aspect of it.
And in this case, would you treat to the same trough level? So is it different?
Yeah, the trough level is the same, but usually when we start on once daily tacrolimus, you need a slightly higher dose. If you, for example, if the patient is on just 1 milligram BD of tacrolimus, so the recommendation is to go for a slightly higher. So the ratio is 1 to 1.25. So you would go for a slightly higher, like 2.5 milligrams of once daily tacrolimus if the patient is on 2 milligrams daily of twice daily. One.
And one question on that case that you presented, I saw that in the initial period, even before the ASTLT rose to thousands, it was around 400, then 700, and the bilirubin was 9. What sort of cutoff would you be worried in this type of patient after transplant?
Well, that is a good question, but because there are a lot of factors. Because especially if the liver graft is fatty, then you would expect a degree of reperfusion injury in the immediate post-transplant period, and when you would expect or if there's a long cold ischemic time, then you would expect the liver functions to be very high in the thousands in the immediate post-transplant period. I wouldn't say that there is a cutoff for that. The only thing is that we need to monitor them frequently and monitor especially the lactate levels, because that will reflect on the graft function. Because the worst thing that can happen is a delayed function or a non-functioning graft. And in that case, you will see that the lactate levels and the INR are not improving. And I think it's better to go with that as a cutoff rather than just look at the liver function level, the ASTLT level. Because as long as the AST level comes down within 24 hours or 48 hours, we are not too worried about that.
I think those are the only questions that have been sent in with it. So I would like to thank you on behalf of the Sri Lanka Society of Gastroenterology. We know that you are a bit under the weather, but thank you for going ahead with the presentation, and it was a very very informative one. Thank you again for that presentation. Thank you. And as our next webinar, we are going to have a bit of a different format. It's going to be a combined session with the College of Oncologists on colorectal carcinoma with liver metastasis. It's going to be on the 3rd Sunday of February. That's the 20th of February, same time. I hope all of you will join with us on that day as well. Thank you.